was asked to discuss my algorithm for ISR and as it relates to DCBs, I guess drug-coated or eluting stents, and as well as covered stents. So if I have to begin, I guess looking at it in reverse, it's an area, a lot of variables come into play. So I sort of think to myself, the algorithm that I have is sort of in my mind. It starts with questions. What are we doing this for? How many previous interventions? When were the last interventions? Do we have information on what was done previously? Because ultimately it comes down to biology and technical defects. In other words, if everything was done right, that's one thing. If it was done with suboptimal results, was that the cause, or is it just the biology? Because that's a different obstacle altogether. So with those questions in mind,
I have no disclosures to report.
I have some speaking honoraria from Terumo as well as Abbott. It's not going to affect what I say here today, but let me begin this by saying that no matter what we do, the technology has improved over the years, but ultimately it's the biggest obstacle that we currently face. It's something that everyone's going to deal with, and what's the best approach to dealing with it is that recognize it's going to happen and begin by an approach that's going to alter the second stage, because there always will be a second stage. And whether you're a believer of the thought of or philosophy of not leaving stent behind, or if you believe in stents, what type of stents you're going to use, that all begins in the algorithm. But for the sake of this, for the time that we have 10 minutes, I'm going to focus on what happens when it occurs and what's the best option. So what contributes to this, if you keep this in mind, there's obviously the variables of biology that goes with what was stated several times earlier today. Is it the intimal hypoplasia, the bulk of the cell deposits, or is it actually thrombus that's present? What type of vessel are we talking about in terms of location? Yes, it's fempop, but there's flexion points, there's impingement on branches and so forth. What are the comorbidities? You know, is everything managed appropriately? What type task lesions are we talking about? Is there coexisting calcium? What's the length? Is it an occlusion? And what are all the variables? Was it overexpanded stent, underexpanded stent? Do we have any information on what was done before? So with that in the background, in terms of your thought process, I guess the best way to go forward thinking about this, and it's been approached, is how do you really classify them? Because there's ISR and then there's ISR. Is there a coexistent occlusion? What's the length of stenosis? Is the stenosis actually in the stent, or is that the candy wrapper ends, top and bottom? If you have a focal stent that's in the middle of the vessel, yes, the stent is closed, but let's say you lose all of the SFA proximal to that. Do you consider that a previously treated area, even though it wasn't treated? So to begin with, let's look at some of the guidelines. Last, as per ACC and AHA here in the US, were they real clear guidelines? The answer is no. Even the Europeans don't have distinct guidelines. There's some suggestions, but ultimately none of it is really based on really strong evidence to this point. So as I mentioned, there's different options, not to impinge on anyone's presentations, but my focus today is supposed to be the DCB, the drug-eluting stents, and covered stents. So a few years back, and I think this is not of any question in anyone's mind, there's a meta-analysis that I think summarized the trials for DCB versus plain old balloon. I don't think anyone doubts that plain old balloon is not the way to go. You can see that the benefits of drug-coated balloon is obviously much better, and that goes for all the three trials that they focused on, and significant impact. So I don't think there's any doubt in terms of whether we use DCB or not. And they even broke it down into the variables that we feel may affect patency more, lengths, reference vessel diameter, and so forth, which I think is a big issue, presence of calcifications, and so forth. So DCB, obviously better than drug-coated balloon. What is the patency of the DCB for TLR for in-stent stenosis in all these trials? Approximately 90% at 1 year. 1 year, not that great. As was previously discussed in one of the other talks, you start seeing a drop-off after the second or third year. So what do you do for more longer durability? Borrowed these slides from the recent Viva presentation in terms of subgroup analysis of the impact balloon in terms of drug-coated balloons. And we could see that average length lesion for these ESR were about 17 centimeters. About a third of them were occluded. Significant number of them were calcified, and the overall stenosis for the non-occluded in particular was high grade. So what do we find at 5 years? Freedom from TLR, 58%, which to me I think is actually pretty promising results, given that historically the benefits of any of this have not been great. If you can promise a 50% stenosis rate, it's information you want in the back of your mind as you come up with an algorithm, because it really comes into play in what you were doing this for and so forth. Well, how about the drug-coated stents? Paclitaxel, a few years back, they had some of their results for freedom from TLR, and 12 months, 24 months, it was 81 and 61%. Well, what's the follow-up to that? recently had some newer data that's come out, and it's important because it's hard to compare some of these trials because there's no back-to-back trial for DCB, covered stents, and standard stents. And that's one of the issues because there's so many variables, and when you deal with PAD, even limited to the SFA pop, as you mentioned, occlusions, long segment lengths, duration, size of the vessels. But we notice here in the original study, if you look at the previous interventions, which is a variable that often isn't broken down into enough categories to count for those variables at low volume, significant number of these will have second, third, fourth interventions. Is it fair to really clump them in with the other group? Because biologically, they may be a more aggressive bunch. And what is the length of time between those? So if you look at long-term, the drug-coated stents in terms of the recent 5-year data that they have for a group of patients that they followed, 5-year from clinically driven TLR, 73%. It's actually pretty impressive as well, all things considered. If you're talking about freedom from TLR for drug-coated balloons in the upper 50 to 60 range, TLR for drug-coated stents, 70% range. Can't say whether one's better than the other, but they're actually quite impressive. So out of 5 years, even though the total number of patients remaining isn't very significant, you have numbers of 78% is pretty impressive. Well, how does drug-coated, how does covered stents fare? Viabond that went forward with their trial in terms of ISR, and again, the total occlusions, not so high. They weren't 30-something%, but they were 23%, had calcified lesions, and the lesion lengths also approximately 17 centimeters. What are their results? Freedom from TLR, well, they had probably patency rates of 74%, and TLR rates 79% at 1 year. Presumably, there's a group of patients that had worse disease, more advanced lesions, because you sort of can't account for the fact that you would choose a covered stent. As was mentioned earlier today, you're dealing with thrombus. A lot of times people are biased in terms of putting a covered stent in because it's lined with thrombus and so forth. So how can I put this all together in terms of my algorithm? Most important part, I guess, is the timing of the reintervention. Second part is, what were the previous treatments? Were they stents of small caliber, large caliber? What type of stents were they used? Were they involve a drug? Because now as the years go on, there's been a transition. There's a lot of OBL work being done where maybe they don't use drug-coated stents. So you really have to find out what that information was on the previous treatment. Where is the location? Which vessel? Is it close to the profunda takeoff? Is it the pop or the flexion point? Is it occluded? What's the length? Is there stent just in a focal area? Piecing this all together in your mind is when you come up with the steps. This is a paper that we came up with our group just shortly, because I think one of the real questions is, what happens if you watch them? There's one thing if you're doing this for critical limb. It's another thing that you're doing for claudication. You know it's not going to last. You know the second intervention is probably not going to last as much as the first. The goal was to buy time. We followed a lot of these patients with 50% stenosis, and over 18 months, yes, some went to occlusion, predominant portion of them went to 75%. If you can follow them closely, you can buy yourself a year's time with no intervention at all, just best medical management, which I think is probably the wiser choice. So if I can piece it together and put it together, there's ISR, first reintervention. The way I look at it is, if it's a non-stented area, pretty confident that DCB works well. If the DCB has a recoil or there's anything either with IVUS or angiogram that you think it's not fully expanded as well, we'll proceed with putting a paclitaxel associated stent or a Viabond. If it's a stented area, I ask myself on imaging or IVUS, what's the size of that stent? If it's a 6mm stent or less, I use a DCB. Larger vessels, greater than 6 centimeters, I have less hesitancy to reline with a second stent and or a Viabond. Reason with the Viabond is, if you believe it's biology, I have my personal preference that I think if there's multiple long segments, hard to say what's thrombus, it's what's intimal hyperplasia. If you could exclude a lot of that biology from the bloodstream, I think it does help. You do have lesions above and below, but ultimately there's no data overwhelmingly to suggest one is better than the other. Next group, which is really the critical one, is what happens when they come back with more than 2 previous interventions, or that it's been less than 6 months since a previous intervention. You know the imaging dictates from previous, if you have it available, everything was done technically satisfactory, you don't see any stent fractures, so forth. In those situations, greater than 2 interventions, if there's never been a stent placed in a particular area, certainly I would put a stent in that area, use a Viabond. If there's a stent, again, if it's a small caliber stent, a lot of these petite individuals, small vessels, 4mm with 5mm stent, I'm not sure relining that with anything is going to have any significant patency. I consider a bypass. When I consider bypass, I consider vein. I certainly don't want to discuss a topic someone else is going to touch on shortly, but if the vein is not an option, then I will reconsider paclitaxel stent in a small caliber vessel because I think the bulk of a Viabond in a small vessel might not be ideal in terms of infolding and full-size expansion. If it's less than 6 months again, and there's a large caliber stent placed, then again, I consider a Viabond or a bypass. So in summary, has a lot to do with what was done the first time, a lot to do with the biological factors. The data doesn't really compare any of these three options, but I base it on size, reintervention rates, segment of disease, and so forth. So the evidence of success over previous existing approaches exists, that DCBs, covered stents, and drug-eluting stents definitely provide a benefit. Comparing those head-to-head does not really exist at this point. This should certainly be a targeted population for first-time treatment, should be a different population for second and third-time treatments, and depending what size vessels we used. And we certainly needed a comparison for all of the above. Thank you very much.